Hi, my name is Cynthia Shechter. I'm a breast cancer and lymphedema therapist. I previously had an office in Manhattan, in Midtown, and I just recently relocated to Bergen County, New Jersey. I've been practicing in the specialty of lymphedema for approximately 20 years, and I'm pretty committed to this population because I think that it is an underserved and underspoken about problem that people have. So lymphedema is actually one of the most poorly understood, relatively underestimated, and under-researched condition and complication of cancer and its treatments. In 2006, there was a report published by the Institute of Medicine of the National Academies. And what they said was that there has to be a survivorship plan for every single patient. The survivorship plan should communicate information about late effects of treatment, risk factors, health management behaviors, disease management, and recurrence monitoring. In my personal opinion, it should also include a rehabilitation plan for each individual patient, because of course, cancer can take a hit on a lot of different aspects of someone's life. The Institute of Medicine also highlighted that there are so many shortfalls in the transition from treatment to survivorship. And actually, I know that from my patients alone, quite often people feel that they don't have the support that they need when they're done with their treatment. And it's a very scary period because that transition is just terrible. So what is lymphedema? Lymphedema is an abnormal collection of lymphatic fluid in the body, usually in the area where there's a lymphatic vessel dysfunction. Lymphedema is known to be progressive and chronic. However, with treatment, you can control the fluid collection and the progression can also be controlled. Lymphedema can be both primary, which means that it's of unknown origin and it came from, a birth defect or some sort of lymphatic condition, or it could be secondary, where it's due to disease, injury, surgery. For the purpose of this presentation, I'm focusing on secondary lymphedema due to cancer because of the population that I'm presenting to at the moment. According to research, the most common cause of secondary lymphedema in the United States is actually breast cancer. You can see in these images that people have deformities and changes in their bodies, and they just want to be back to themselves. So therapists like myself focus on getting people back there, getting their swelling down, making things less obvious so that you can get dressed in the clothes that you want to, so that you can go about your day, so that you can live your life. So when does secondary lymphedema occur? Often after the removal of lymph nodes and or radiation therapy. It happens with many different cancer types, with or without stage 4 disease. Some of the most common are uterine, urinary, breast cancer, squamous cell cancers, gynecologic cancers, and melanoma. Research says that lymphedema typically occurs 2 to 3 years after cancer treatment, but the risk of lymphedema is lifelong. So I've had patients come to me 30 years post-treatment who all of a sudden fell on an outstretched arm and ended up developing a lymphatic condition and were devastated, thinking that the risk was over. So what are the symptoms of lymphedema? Lymphedema is currently estimated to impact between 2 and 3 million people in the United States. And this number is probably not inclusive of people with mild symptoms because they don't realize that they actually have a problem. So symptoms of lymphedema. You may feel that your clothing is tighter, your jewelry doesn't fit right, your arm is achy and heavy. You have observable mild change in your extremity, wherever it is. Lymphedema is said to have a high physical, functional, quality of life, and economic consequence. So benefits for lymphedema treatment need to be improved, because lymphedema, again, is a chronic condition, and we can't stop treating diabetes, because if we do, somebody will end up in a diabetic coma. I believe that lymphedema is the same. People cannot live without treatment. And I think that the incidences of lymphedema are likely underreported because mild conditions are not necessarily taken seriously. And I believe that it varies. So even when I look at the data, they say between 6 and 63% of individuals who undergo an axillary node dissection develop lymphedema. That's a very big range. So to me, I say, you have a 50-50 shot, and we're going to do our very best to try to make sure that you don't develop a lymphatic condition. And this is done with rehabilitation, post-surgically, post-radiation, to improve range of motion, to improve lymphatic flow, and to make sure that everything is moving and healing appropriately to decrease risk. So what is the risk of lymphedema? Infection. So what happens with the lymphatic system is it not only circulates lymphatic fluid, but it also breaks down large protein molecules and bacteria to cleanse the system. As you see where I circled in the slide, this individual had a bee sting to her forearm, and it was developing into a cellulitis infection. This was 4 days after the bee sting. So I referred the patient to her physician, and she was put on oral antibiotics, because this redness can turn into an infection that is systemic. Cellulitis infections can become dangerous. You can lead to sepsis. So you have to pay attention if you have redness and warmth in an area or increased swelling that is inexplicable, go get checked, because you probably need antibiotics. Sometimes you feel like you have the flu. Sometimes you feel pain. Sometimes it's just red and hot. You have to pay attention to your body and make sure that there are no issues happening. Also, if you're going to travel, ask your physician if you can have antibiotics on hand, so that if something does happen, you are able to actually get what you need, and you have the medication for yourself right there. So as soon as an infection starts, you're ready. So lymphedema after cancer treatment is common. And it's important that we look at the quality of life of individuals. I think therapists in general, we have a tendency to tell everyone the things that we've learned that they have to do, but we don't necessarily find out what someone is able to do. So it's important to evaluate the symptoms of lymphedema, and it's important to evaluate people's overall quality of life and well-being. What are they going to be able to do to control their lymphedema, and what are we going to do in order to get them there? As you can see, the woman in the image to the right has pretty significant lymphedema in her left arm. You can see that it likely limits, particularly thumb movement, more than likely wrist movement, and shoulder. I believe she has significant limitations, and as you can see, her shirt is tucked up underneath her arm. That's likely because she does not have the appropriate range of motion to get her arm moving, which closes lymphatic pathways. So if you have a lot of scar tissue in an area, how is the fluid supposed to pass? We have to break that down. We have to work on it. And that is something that most of us don't do. Most people either treat lymphedema or range of motion, but it generally doesn't go hand in hand. And to me, that's the direction that rehabilitation should probably go. Aside from the advances in the identification of lymphedema, there have been advances in its treatment to offer insight and improvements into the management. It is considered a chronic progressive disease, but that does not mean that you have to progress. It means that we better get the lymphedema stable prior to there being an issue. Sorry, it changed slides too quickly. So I think clinicians have to identify early symptoms and signs of lymphedema and make sure that they facilitate a really fast referral to a clinician who specializes in the treatment of such a disorder. I also think that physicians postoperatively should have a direct script so that a patient post-op lymphatic surgery should be referred directly to a therapist, whether it's a PT, an OT, there are nurses, there are massage therapists. I think seeing somebody who has a clinical background in lymphedema is so important, and somebody who has the clinical knowledge of what to do to break up scar tissue, to decrease any symptoms that you have left over from cancer treatment. There are only 3 states in the United States that mandate coverage for the treatment of lymphedema right now. That's Virginia, California, and Massachusetts. The Lymphatic Education and Research Network has recently assisted in getting the Lymphedema Treatment Act passed through Congress. But there are so many logistics to work out that the mandated coverage isn't there. So the insurance companies don't necessarily follow this mandate, nor do they pay attention to the amount of time that a therapist will spend with a patient. It's at least a 60-minute hands-on therapy session, followed by exercise. So there's a lot of time that goes into it. There's a lot of arguing with insurance companies for reimbursement. Your clinician should be in charge of the arguing. I argue all day, but that's part of my job because I like to take care of people. So what do we do to manage the symptoms of lymphedema? The goal overall, we all know, is to decrease the size of a limb, to improve the symptoms, to decrease aching, sadness, fullness, and to improve quality of life, to develop an individualized lymphedema treatment plan, to meet each person's schedule, lifestyle, etc. When lymphedema therapy first came about, people weren't as busy. We didn't work as hard. We weren't home. We were home significantly more. Now, everybody leads very busy lives, and the management of a condition needs to work within somebody's schedule and lifestyle. So self-management would include bandaging, use of a pneumatic pump, compression garments, all in an effort to decrease swelling and to decrease the risk of infection. Now, if somebody notices that their compression garment is rubbing a sore, then clearly it is not going to help prevent infection. It's an ill fit, and we need to get you a new one. This is one single patient who I'm going to use as an example, because if it feels wrong, it probably is. And unfortunately, in this world of medicine and life, we have to self-advocate. So this patient is actually from Wisconsin. She began by emailing me in the beginning of October regarding her swelling. It's new onset, and she's 6 years post-op. She's never had therapy for range of motion. She's done therapy for lymphedema in the past, but never had a real problem. Now, if you look at where I'm circling, these are the areas where she has fluid that has pooled. When I come to the next picture, this is the same patient. She was actually seen by a certified lymphedema therapist for one visit. She was wrapped by the clinician, but the clinician had never wrapped anyone before, nor did she have any mentoring. So look at the fluid pooling in the hand. You can see her knuckles a little bit better, but look at this area right in the top of her hand between her thumb and the bottom of her MCP knuckles. Then the whole arm seems to have had an ill reaction to whatever it was that was going on. So if we look at her forearm and her elbow area, it looks like it actually got larger from the wrapping. That would be a sign that the therapist has to change the way in which they wrapped. So the patient contacted me and was desperate for assistance. The first thing that I saw was that she had a small little channel of nodes on her arm. I thought that perhaps she had something called lymphangitis, which is an inflammatory process of the lymphatic vessel. It's infectious and it's treated with antibiotics. So I had her get antibiotics. I did FaceTime calls with her, teaching. Her spouse and herself had a wrap. And finally, she had some improvement. Now, this was without even seeing me. I just changed the way in which we were wrapping her. And I paid really close attention to how her body reacted. The patient also has rheumatoid arthritis, which is something that I have to take into account because with too much aggressive therapy to this area of her hand that I circled in image number 2, her knuckles get very inflamed with compression. So I have to be careful not to use a ton. The patient actually flew to New Jersey to see me and is doing wonderfully. She's actually here this week, and it's really exciting because it's like it's a test for both of us. And it's nice to see that she finally feels like she's getting a little bit of control over her situation. So these are images of secondary lymphedemas. The first picture is a young woman who had she had a bilateral mastectomy, but her right side is affected. She had a lap flap reconstruction, which is from the latissimus muscle. She had radiation therapy, a failed lymph node transfer, but successful therapy. So do her arms look exactly the same? No, but does her arm look typical? Does it have normal contours? She was about to go get married. So my job was to get her ready for her wedding. And she was so excited that she was going to be able to go without a glove, without a sleeve, and to actually look like nothing was the matter. And that was so important to her for her wedding. She ended up with breast cancer in her late 20s. So here she is. Next picture is a picture of a woman who underwent a transabdominal hysterectomy due to cancer. She had a pelvic node dissection and radiation therapy to the pelvic region. She had therapy, and you can see she scraped her knee, and her stocking is no longer fitting appropriately. So if we look at her ankle, you can see all the creases and the redness. At the top of her leg, you can see that the compression has a bit of a tourniquet effect. So is that really going to help her reduce her swelling? Probably not. I think that we probably would have to make a change for her. Perhaps change her garment, perhaps put her in a thigh high. Even though her swelling in her thigh is minimal, there is some noted change in tissue in this extremity, even higher up than her knee. So perhaps also treating her and putting her in a different type of garment would help. The third patient actually underwent a left lumpectomy. She had radiation therapy to the breast and was diagnosed by her physician with cellulitis. She was overtreated with oral antibiotics, ended up with significant stomach problems, and now can only have IV vancomycin. She would take her antibiotics, and there was never any improvement in the color, size, or texture of her left breast. You can see how swollen it is. After extensive evaluation, I actually recommended a tissue biopsy because I was afraid that something else was going on, because generally people don't have no response to antibiotics, and generally they don't have zero response to therapy either. But unfortunately, she was just not getting better, and she did not feel well. It turned out she actually had inflammatory breast cancer, which shows up similar. It's like this picture where you have redness and peau d'orange and swelling and discomfort in the actual breast. And unfortunately, the patient's treatment didn't work and she perished. And that is terrible. But sometimes things do go under-observed. So we as humans have to make sure that we're always advocating for ourselves. And it's exhausting. That's our job. We only get one body and one life. So what is the psychosocial impact of lymphedema? We know that participating in our roles of life is part of what is so important to us, and part of what we enjoyed prior to diagnosis. But for some reason, these conditions, lymphedema, swelling, everything gets in the way. And unfortunately, we're then unable to overcome. So we have a fear of picking up children, groceries, laundry. I always tell my patients that I'd rather them live with lymphedema rather than for it. Because if you live your life for the fact that you have swelling, then I don't believe that you're really living your life. People have an altered body image. Their self-confidence and self-esteem is significantly less because all that they see is their swelling and the fact that their bodies are just not working with them. Mei Fu is a research nurse from NYU. She has researched lymphedema and psychosocial effects as well as physical effects of exercise. She's really quite brilliant. She talks about the necessity to meet the basic needs, to be able to sustain your family. You don't want to require assistance to be able to reach and lift things. If your child falls in the playground, you want to be able to pick them up. People feel less desirable and less desired by others. They don't even want to be with others because they feel ugly or judged. This is horrible. We have to do something to stop the train and get things under control. And it's all a matter of what we do. People can't sleep because they have either discomfort in their extremity, or they actually just feel so poorly about themselves that they can't get over it and they can't get themselves to sleep because they're so overwhelmed and so in fear of progressing to an elephantitis. They have difficulty in their work role where, you put your hand on your desk and you go to type when you're in a meeting. And if one hand is so much larger than the other, then people feel embarrassed. And generally in the United States, for some reason, it's okay for a stranger to walk up to you and ask you what happened. And I don't believe that most people want to tell. And I don't believe that it's right that people think that it's okay to ask. I would never ask somebody what happened to them. I would ask how they're feeling, perhaps. I would never say, oh my God, what happened to your arm? And the problem is that when people have that conversation, they feel horribly. And then what do? You're stuck. So what can you do? We can look at the support community that does in fact exist for lymphedema and cancer. So we have to find a way to have a good psychosocial adjustment post-cancer. I know that this chart is for breast cancer, but it's effective for all cancers. Everyone who has the protective mechanisms to self-preserve, you need to actually be able to cope, to manage your symptoms, to understand them, to know what to do about them, and to have an entire psychosocial adjustment. And that is the job of your entire medical team. And even though this image is from 2002, it hasn't changed. This is what we have to do. It says post-breast cancer, but I say post-cancer. We need to help people with the psychosocial adjustment because there are changes in your life and it's not an easy change. Nothing about cancer is easy. So what do we do for lymphedema? Lymphedema is one of those things that everybody fears and nobody wants. And it is said to be progressive. It's said basically the way that things are written, we say that, eventually it will get bad. Is that true? I don't think so. I think that we should be able to intervene early, and help patients get themselves under control. So we do things like manual lymphatic drainage, which is the image here, where the woman is actually working on sending fluid to a different area in the body because this patient has lower extremity swelling. We do multi-layer compression bandaging, like you see in the picture where the woman is doing the wall stretch. Compression garments, like the person who's walking here in her compression stockings. We use a vasopneumatic pump, which I don't have imaged here because there are so many different ones. There's the Flexi Touch. I like the Aeros, the biocompression, even the LymphaPress. There are so many different machines and each one works slightly differently. And are any of them a standalone treatment? No. But can they assist in self-management? Absolutely. The only device that exists for head and neck swelling is actually the Flexi Touch. And they have a nice garment and it does work. It goes on the neck and face and it helps get rid of some of that fluid. You have to pay attention to your skin. The reason for that is because lymphedema and poor lymphatic function can increase risk of infection. So what do we have to do? Make sure that our skin is moisturized, make sure that we don't have any strange rashes, apply cream on a daily basis. We want to look at exercise. What can we do to increase the way that your lymphatic fluid is moving? Muscle movement moves fluid. So what can we do? There's plenty of exercise. And as needed, you refer to a mental health and other professionals so that you can help your patient get better, mind, body, spirit. And I truly believe that there's a lack of cross-referral and people need our help. And as a clinician who specializes in this area, I will refer patients directly. I will contact their physicians for referrals. I will do what I have to do to make sure that people are doing okay. Because lymphedema is actually very hard to deal with. It is a physical and visible condition. And unfortunately, visible conditions can't be hidden. So manual lymphatic drainage, what even is it? You can see these people are certainly working on extremities. But what are we doing? It's a hands-on technique where we're mimicking the anatomic lymphatic pathways. So we're sending fluid from pathways where they're all clogged to the healthier pathways so that the fluid can be reabsorbed by the body so that you can actually see and feel an improvement and manage that swelling so that it doesn't turn into an elephantitis. In the elbow, as you can see where I'm drawing circles, there are nodes right here in the ulnar side. It's actually the medial elbow is what it's called. And if we could stimulate these nodes and send fluid there, well, then doesn't that make sense? Because we're sending the fluid from the area where you're the most challenged, which is generally at the hand, all the way up. And as you see, there's arrows that go up the upper arm. You work the fluid to the outer upper arm and then upward. The idea is the firmer the tissue, the firmer the touch. So for anybody who has ever felt lymphedema or lymphatic dysfunction, there is a difference in the tissue texture because of that bacteria and protein that gets built up. So we are working to transport fluid from a congested area to a healthier area where the lymph nodes are ready for fluid reuptake. The pathways in the neck, the unaffected armpit, the unaffected groin, the abdomen, the trunk are activated and facilitated by the manual therapy. So it's really important to get that manual. A session usually lasts 45 to 60 minutes. And I usually see my patients 2 to 3 times per week for optimal results. Now, my patients are not wrapped 24 hours a day, 7 days a week, and they are not discharged to wear a compression sleeve every day. Because honestly, to me, I don't know how much better I would feel if my arm was less swollen, but I had to pay attention to it all the time. And having less swelling, which clinically doesn't make sense, of course, because I'm increasing a risk of infection. But of course, we all want to see the visible change. The visible change is important. So here's images of somebody with pretty severe elephantitis of the left lower extremity. You can see the image from before treatment and after treatment. The increased lymph production, it increased the fluid collection in the lower extremity. When we stimulate the system, we move the fluid towards the quote unquote normal lymphatic drainage pathways. So we're reversing the flow so that we can send that fluid to healthier areas so that we can actually get it out. What effect does that have on an individual? An individual will feel a soothing effect. Generally, it promotes pain control because you're getting rid of all the noxious substances that are sitting in that tissue. So the ache is less, the heaviness is less. Sometimes the nerve pain is less. When you're very swollen, your nerves get pushed to the surface of your tissue and you're much more sensitive. So sometimes we have to do some desensitization so that people are actually able to tolerate the feeling of their leg or their arm or even their breast or anything else. So multi-layer compression bandaging. It's applied after manual lymphatic drainage. Generally, my patients sleep in bandages, wake up in the morning, take them off, and go about their day. They provide a working pressure to stimulate lymphatic flow. So when you're wrapped and you're moving, you're actually working to decrease tissue fibrosis and to decrease the size of that extremity. So then wouldn't it make sense to not sit and do nothing, but to wear the bandages and actually exercise, go out for a walk, do overhead hand pumps. They're wonderful exercises where you're opening and closing your hands. You're tightening your shoulders as much as possible. This is another exercise that Mei Fu found would help prevent lymphedema because, of course, muscle movement and muscle pump moves fluid. These bandages, just for one more short term, these bandages are actually short stretch. So even though they look like ACE bandages, they're not. They allow your muscles to pump against them, and it creates a wave-like fluid flow. And that wave-like fluid flow actually helps get the fluid out of the extremity. So for me, would I rather have a patient sit on a pump for an hour or wrap and go out walking? I always say wrap and go out walking. It's a healthier activity. We're getting you active, some cardiovascular, but also we're creating a muscle pump and we're actually working towards decreasing the swelling even more and in an even more effective fashion. So compression bandaging. The bandaging provides a working pressure, like I said, it helps pump the fluid out. Now, the techniques differ. We are taught to create a cone-like shape of the extremity, but our extremities are not shaped like cones, so that doesn't always work. And also, using lots of foam makes it very difficult for people to get dressed and live their life. So I prefer to keep the bandage actually as small as humanly possible, because when I do that, it increases function, it increases movement, it increases extremity use, and it decreases the girth of that extremity. So once the fluid is pumped out, the bandages continue to stimulate the flow with the muscle contraction against the short stretch bandages. And that is where you see an improvement. So then the clinician can decide what is an appropriate regimen for each individual. Our job as clinicians is not to dictate all the have-tos in life. It is to find the things that your body needs and to identify the things that we can erase or remove from your entire plan because it just doesn't work for you. So it's the individualized treatment that is so important. Exercise. What types of exercise are we talking about? Remedial, flexibility, breathing, resistive, and aerobic. You have an individual here on a mini trampoline. That has been the gold standard of exercise for lymphedema because they say that it does create that fluid pump. It may, as does the vibration plate that this woman in the blue shorts is standing on. That actually creates muscle oscillation and it gets things moving. So as she's standing and the machine is vibrating, it's actually stimulating that fluid to go back to the body. We can also do stretching. The stretching exercises improve your flexibility. Flexibility is of the utmost importance because if you can't move, then that means that there's scar tissue that we haven't addressed and we need to. Core strengthening, particularly after you have breast reconstruction with a flap surgery. You have to strengthen your core. You have to get back to where you were before. So what are some quote unquote remedial exercises? Remedial exercises are just movement based, really. They're not resistive. They're of the affected body part and you move. Generally using the short stretch bandages, but you can move without them as well. And what you're working on is increasing the return of lymphatic fluid to the rest of the body. It could be something as simple as doing ankle circles, arm circles, shoulder shrugs, knee bends, ankle lifts, knee extension, chair squats, even Tai Chi. All of these exercises are remedial, but they increase fluid flow and they increase your range of motion. So when we're looking at flexibility exercises, we're looking at actually stretching out the scar. We're looking at stretching out any axillary web. We're working on increasing range of motion, getting rid of joint contractures and scarring, slowing the gradual progression. We are reaching to the point that we can, but if your body starts to bend in a funny way, then that's a compensatory movement that we have to stop. That's why I think that even just a 2-week stint of therapy for anybody post-cancer treatment is important because we can really teach how to prevent injury while still increasing range of motion and promoting increased movement and an increased quality of life. So resistive exercises. Here we have a woman who clearly underwent some sort of left upper extremity, left breast cancer, has left arm lymphedema as noted by the purple sleeve. We can see a few things from this picture. Number one, she has decreased muscle mass on the side that is affected. We can see that she has a little bit of decreased movement of the shoulder where her left shoulder is actually coming in and you can see the therapist's hands are trying to guide her shoulders so that that does not get in the way of her function. We do low weights, gradual compression, reducing the limb size when used along with compression. We improve function and quality of life. People can fully perform the essential duties of what they do, such as standing, walking, carrying, playing with their kids, maintaining their social lives. If we help people get stronger and we help decrease the size of the limb and we help people gain control over their situation, then we have helped them get back to their life. That's the most important thing. Some other exercises, overhead pulleys are wonderful. Seated rows are really good, especially post-breast cancer, when people's postures are limited because they're used to standing in a very rounded position post-op. We can talk about aerobic exercises. You want to assist in reducing and maintaining the girth of the limb, maintaining weight, improving quality of life, muscle conditioning, and even heart and lung capacity, which is affected by things like radiation, chemotherapy. A lot of the drugs are cardiotoxic, so getting back to aerobic activity is of the utmost importance for overall health, not just for lymphatic health. Swimming is a wonderful aerobic activity. You do not need to wear compression. Actually, the water plays a similar role to the compression bandaging itself, where it provides a working pressure. So as you're doing freestyle through the water and you're pulling through, you're actually creating that same working pressure. If you go walking, you're stimulating your endurance, you're getting a muscle pump, and you're stimulating your circulatory system. Using the bike, excellent. Even more so for lower extremity swelling, because of course you're using your legs. Yoga is a wonderful exercise. It actually addresses both aerobic flexibility and remedial exercise, even strengthening depending. In yoga, people use down dog. That's a lot of pressure on the body. You have to make sure that your arms are ready to take that pressure, that your legs are ready to take that pressure. If the activity is increasing your swelling, stop. If exercise is causing any type of joint pain, numbness, tingling, burning, excessive pain, or swelling, stop. Contact your therapist or your physician and discuss the symptoms that you're having, because who knows why? Maybe the exercises are the wrong ones for you, and maybe it's just that it's not, something is not right. So there's lots of supporting research for lower extremity lymphedema and exercise. So strength training assists individuals with lower extremity lymphedema in improving their function. Well, doesn't that make sense? If we can strengthen the muscles so that you can lift a heavier limb, then we've already helped you to become more independent, to be more mobile. There was no increase in lymphedema while wearing compression garments for activity. Now, I think those were probably very good fitting garments. I think that we also still have to take into account whether or not a garment is fitting right. If somebody exercises and they find that they have pooling of fluid in an area, then that garment that we had them in is not working. As far as upper extremity lymphedema, exercise is an essential part of a healthy lifestyle for anyone, and it's essential for effective lymphedema management. It just is. 8 weeks of yoga actually resulted in an improved tissue induration of an affected arm. Induration is that protein-rich fluid. If somebody is swollen and they press on their forearm, that is where they will see fingerprints. That's the protein buildup. So manual lymphatic drainage combined with an individualized exercise program helps improve the symptoms of lymphedema. And we can help improve the functional and physical impairment experienced by individuals, as well as decreasing their psychosocial distress. Now, this sounds like a very obvious thing to say, but what I will say is that we have to pay attention to every symptom that people are having. And honestly, oncologic rehabilitation is of the utmost importance. We think about lymphedema. We generally think about lymphedema due to breast cancer. Lymphedema due to breast cancer happens, but does lymphedema due to breast cancer, is that the only lymphedema? And I did a recent lecture for the Lymphatic Education and Research Network, and one of the participants asked me, why is everything about an extremity? My swelling is in my face and neck. And you know what? She was 100% right. When people do presentations on lymphedema and cancer, we have a tendency to focus on the extremity. But of course, that is not the only area where you could have swelling. If you have radiation to the lymph nodes in your neck, you will be prone to lymphatic dysfunction that could affect the face. Now, that's a very difficult condition to contain, and it's a very difficult condition to have because you feel relatively lousy about yourself. So my job as a clinician is to help people feel better in that situation, to get them to a point where they have control over their swelling, where it doesn't look wrong, where people aren't looking and saying that somebody has a strange dysfunction or look at her. that is not what we want people saying, and that is not what's appropriate. What is appropriate is for us to give you and anybody in need the appropriate care that they need. And it has to start with rehabilitation. You can participate in rehab during treatment, during radiation therapy, during chemotherapy, post-operatively. If your doctor clears you, there is no reason you can't participate. The only time there's an issue is when somebody's in isolation, and that only lasts for a short period of time. So there's actually plenty of time for people to find care. The problem is that a lot of the time, physicians forget about rehab. It's not because they don't appreciate us. It's because they have a lot of other things to pay attention to, and that makes it difficult. So that's okay. Our job is to be sure that we keep putting ourselves out there and that we make ourselves known to the physicians so that they have where to refer, and to make ourselves known in a grassroots foundation so that patients can actually find us. I think it's so important. So in this slide, I've listed a bunch of organizations that are available for help. This is not all of them. This is a list of some of them that I am familiar with that I wanted to share. They have lots of different offerings, and each individual organization offers a lot. I know that Learn and the National Lymphedema Network work very hard on making sure that there is access to care. The Lymphatic Education and Research Network actually offers a scholarship program that used to be part of the National Lymphedema Network. The scholarship program is to provide partial funding for certification so that more therapists can become certified. But the other thing that has to happen is newly certified therapists have to be able to have a mentor to ask questions, to learn. And that's also missing because there just isn't enough care and there aren't enough care providers. So it's something that we're working on as a unit. I hope that this presentation was helpful. I didn't want to go too into detail about the anatomy and physiology of the lymphatic system because it's complicated and it's not necessary to know every single aspect to be able to manage a condition. And I wanted to keep this very patient-centric because, of course, that's what we need. And that's what we're looking for, is people who can think outside of the box, people who will look at a patient and say, I don't think this is working for you. I want to try something new. Those are the individuals who we need to make sure that we're in touch with. So I hope that you found this presentation helpful. If anybody wants to get in touch with me, I'm happy to speak to anyone. I gave my contact information on the first slide. I hope that my slides are made available to people. And I hope that you found my presentation of assistance. I wish you all the best and hope to hear from you if you need me. All the best. Thank you.